Yes, Dr. Irene, start, please.
Hello, good morning.
Good morning, Doctor.
My name is Dr. Irene, one of the senior house officer in this hospital. Am I talking to Mrs. Sonia, 35-year-old?
Yes, Doctor, I am Sonia.
Okay. We are here to discuss regarding your health condition. I also examine you. Is it okay?
Yes, Doctor, please.
Okay. I have gathered knowledge that you have some lump, you have lumping on your neck. Can you tell me actually what when it started at
Yes,
first?
Doctor, I have a swelling in my neck started few months before and increased gradually.
And it started suddenly or gradually? Gradually.
Gradually, yes, Doctor.
Okay. And do you think that it is pain or in painless? What you feel?
No, Doctor, there is no pain.
Okay, and the lump is increasing or decreasing or same?
Yeah, increase, Doctor, increase.
Okay, I'm sorry to hear. Then, as the any temperature on your lump you feel?
No, Doctor.
Okay. Any other lumps, any part of your body, like armpits, growing?
No, Doctor.
Okay. And do you think that do you have any fever before when you started this lump?
What do you mean by fever, Doctor?
It's the high temperature.
No,
Sorry.
Doctor.
Okay. And do you feel any fatigue?
Yeah, Doctor,
Like
I feel tiredness. I feel tiredness, Doctor, most time.
okay. And what about your weight?
Weight, really, Doctor, my weight increasing.
Okay. And is it intentional or not?
No, not intentional, Doctor.
Okay. And do you think that you are feel more any weather preference, like you like hot or cold weather?
Really, doctor, I am feeling cold most times, so I prefer hot weather, doctor.
Okay. Okay. And Ms. Sonia, during this lumps on your neck, do you have any difficulty on breath?
No, doctor.
Any difficulty on swallowing?
No, doctor.
Okay. Any uh, what about your mood?
Really, doctor, I have no mood nowadays.
Okay, and I want to ask you, what's your work? Any change you notice, any clothing, any
No,
kind?
no, doctor, no change, no trouble.
What about your bowel habit? Do you think any loose or hard stool?
Hard stool, doctor.
For how long is that?
Really, doctor, this is since few months also.
Okay. Miss Sonia, do you have any disturbance on your eye, your visual disturbance, like any pain and redness,
No, doctor.
any double vision?
No.
Okay. Do you have any resting patient with chest?
What this chest? What I?
Heart pressing?
No, no, doctor.
Okay.
But
And
before about 9 months before or 8 months before, I started to develop awareness of heartbeat. But this is improved spontaneous, doctor.
okay. Hmm. Okay, Miss Sonia, what about your period? Is it regular?
Yes, regular, doctor.
Any change or recently any volume change you
Yeah, really,
notice?
doctor. I noticed that the blood amount is increased significant.
Do any what about do you have any long-term relationship?
Yes,
Are you
doctor.
married?
I am married, doctor.
Do you have kids?
Yes, I have one kid, one son.
Uh, and what is the last age?
4 years, doctor. He's four
Okay,
years.
I'm talk to you and I'll also examine you. Is it okay?
Yeah. Yes, please,
Okay,
doctor.
I want to examine the neck and inspect is the lumps over the neck and scar mark
Yeah, this is the
and
neck.
okay. So no scar mark and I want to see the to swallow and I want to see the movement of the lump
Yes.
and I want to palpate the lumps
From
and
where you should
from
palpate?
the behind
Yeah.
and palpate the lumps with swallowing with movement with swallowing or not.
Yes.
Okay, I want to say, so I want to say that yeah, a cup of a glass of water to sip and to swallow and its movement, and I want to see the lymph node Is there
Nice.
tendinopathy? I want to see the hand now. Okay, okay.
Before, doctor.
I want to eye examination. Oh, sorry. I want to see the. Is there any redness? Any lid irritation? Is there any
I
visual?
mean, doctor,
Yeah.
doctor, for neck, for this goiter, what you will examine also, other than palpation.
Okay. I want to see the. I want to percuss to retina extension.
Yes,
Mm,
and
I want to auscultate to any bruit.
yeah, very nice. Yes, okay. Then when
Then I want to see the eye.
the eyes,
Mm,
eye
is there
normal. This is the eye. You see, this eye.
so is there any need fundoscopy to see the optic atrophy?
No
I
need
want to
fundoscopy.
and to now come in the hand to see the sweating palmar erythema.
This is the
Is that
hands.
okay? So so Mrs. Sonia, is there any do you notice that your hand becoming pigmented nowadays?
What do you
Like
mean,
any
doctor?
pigmentation means
Yeah, I
color
see.
change. Yeah.
Yes, doctor. Yes, as you see this skin tanning. Yes, doctor.
For how long it is?
Really, doctor, this is also few months start with me, but increase also.
Mhm. Okay. Is it staining any other part of the body?
Yeah, doctor, I notice also inside my mouth.
Mhm. Okay. Do you feel any dizziness during sitting to standing?
Yeah, really, doctor, yes, I feel like this.
Mm. Okay. And okay. I want to see the now hand and tremor, clubbing, pulse, and rhythm.
Yeah.
Okay.
Heart pulse is regular, 70 beats per minute, and regular.
Okay. Okay.
Blood,
Okay.
yeah, blood pressure.
But
How can you check blood pressure?
I want to see the postural drop present or not.
Yes. This patient
Hello.
has yeah,
Yeah.
she has postural hypotension.
Okay. Oh, okay, Miss Sonia. Do you have any past medical condition that I should know?
No, doctor, I have nothing before. 1 minute, doctor.
Any hospitalization before? Okay.
No, doctor.
Any medication you are taking?
No.
Okay. And any family history of note?
Yes, doctor. My mother has a disease called hypothyroidism, and also she has a skin disease called vitiligo.
Mhm. Okay. And Mrs. Sonia,
30,
do you smoke? Okay.
30
What is
seconds.
your concern? Okay.
Do I have
What is
thyroid? Do I have thyroid disease, doctor, like my mother?
okay, Mrs. Sonia? It is actually what you develop. I have to talk to you and examine you. It is called autoimmune polyglandular syndrome. Not bother the name.
Yeah.
There is a possibility that there is various gland on your body affected, and it's the defense system are attacking against your defense mechanism. That's why you're developing this type of many gland are involved. Your thyroid gland, your there is a
Thank you.
gland over the
Thank
tummy.
you, Dr. Irene. Yes, thank you very much. So it's very important when you see goiter to rule out autoimmune polyglandular disease. Now I will discuss the approach, but your approach was very good, really. So what's your diagnosis?
Sir, yeah, my diagnosis is autoimmune polyglandular syndrome type 1
No,
or no type
not
2,
type,
sir. Type 2, sir.
type 2. Forget
Yes,
type 1
type 2.
exam, any basis
Okay.
exam. Forget type 1.
Yeah, yeah.
Always remember
Type 2.
type 2. Type 2
Yes,
polyglandular autoimmune syndrome.
yes,
Uh,
sir.
type, what's your evidence?
Sir, patient have hypothyroid symptom. Patient have all the symptom: weight gaining, cold intolerance. There's menstrual. There's menorrhagia, and there's pigmentation. There's addition like symptom. There's dizziness and
So,
family.
so she has this patient, she has symptoms of and signs of Hashimoto thyroiditis.
Yes, yes, sir.
And this is also can be evidence that this patient told you that I have also awareness of a heartbeat precede the symptoms. So we know that usually in patients with Hashimoto thyroiditis can have transient phase of hyperthyroidism, and then will develop hypothyroidism. And she has evidence of Addison disease.
Yes,
Okay?
sir. Yes, sir.
Okay. What investigation you will do for this patient?
At first, I will do in this station 5. I want to do specific investigation,
Yes.
like a thyroid function test, and I
Yes.
also do. I want to do also want to do genetic test to see any genetic factor correlate, and I want to do the um, uh, patient had Addison short synaptic test to
Yeah.
Addison,
Yes.
and I want to do the um, CT scan of the abdomen or MRI, ultrasonogram of the abdomen to see any lump over the yeah, over the kidney
Yes.
or any tumor-like
Yeah.
thing or
You
right?
better
Yes, sir.
to do CT for adrenal
CT,
glands.
yes, sir. CT scan. So ultrasonogram I can't. Okay, sir. Okay,
Yeah.
yeah.
What else you will do?
Um, sir. Other than this, sir, I want to do.
Usually,
Yes, sir.
which which antibodies you should do in this patient?
I can do anti uh, anti-TPO, sir. Uh,
Usually thyroid
uh,
peroxidase. If
oh yeah, third parasitic, yes, sir.
usually this diagnostic for Hashimoto thyroiditis, and
Yes,
also 21 hydroxylase and 17 hydroxylase. This is usually on the patient with autoimmune hypoadrenalism. Addison disease should be positive, autoimmune. Okay, what's
yes.
the treatment? How can I manage the patient?
Sir, at first, non-pharmacology and pharmacology, so I'll in multidisciplinary team, non-pharmacological education counseling, and pharmacology.
How can educate this patient? This is very important. In this case, education, you should explain what's education because it's important in this case.
Sir, regarding I want to, I will tell to the lifestyle modification also related to there is as a patient had multi organ involvement, gland involvement. So, counsel over the to prevent how to dizziness, if feel, and sir, actually, the information regarding education, I have no much
For
information.
any patient with hypoadrenalism, what
Yes,
we
sir.
should what we should tell them or advise them. The patient must advise it of serious nature of the condition and need for
Yeah,
compliance
yeah.
to therapy, especially corticosteroids and steroids,
Corticosteroid.
and
Yeah.
need to increase dose of hydrocortisone during illnesses and stress. And the patient also should be provided with medic alert precedent. So any patient with Addison disease or with hypoadrenalism should be advised because this is serious disease. Okay, that to increase the dose of corticosteroids during illness and stress, and also the patient should be provided with medic alert precedent. Yes.
Yes, sir. Yes.
What else? How can manage the patient now? Pharmacological therapy.
Pharmacological therapist, sir. Regarding, I need to I will give thyroxine to his patient
Yeah.
the hypothyroid, and the patient has have I will also give steroid to prevent the patient has developed addictions.
Yeah.
So other than this, the supportive management as patient develop, I'll
So this patient for Addison disease or for adrenal insufficiency, primary adrenal insufficiency, we need to give glucocorticoid
glucocorticoid,
and mineral corticoid,
mineralocorticoid, yes, sir.
mineral fludrocortisone. Okay.
Glucocorticoid.
Thyroid hormone replacement, we need to give this patient for hypothyroidism. Okay, so now questions. What are this is important question. What are the causes of firm diffuse goiter?
Causes of form diffuse goiter. Mm, sir, it may
You
be
see now goiter in patient, goiter,
yeah,
you see goiter. So
yeah.
what's your differential diagnosis? What you should ask
Sir,
patient to know the
is there
diagnosis?
it is uh solitary or multinodular, or is thyroid cancer?
No, no, I tell you the firm diffuse goiter.
Yeah. So what
Diffuse.
question I diffuse? So I must ask regarding compression symptom.
No,
If
no,
I'm
I mean, what are causes
okay, causes.
of diffuse goiter? So one of differential, in this case, Hashimoto thyroiditis.
That,
Okay.
yes,
Also
that
Graves disease,
yes, that yes.
De Quervain thyroiditis,
Mm.
postpartum, and
Okay.
simple goiter, iodine deficiency,
Yes.
physiological goiter in puberty and pregnancy. And last thing, goiter genes like amiodarone and seaweed. So the causes of, if you see the patient has diffuse goiter, firm diffuse goiter, so differential diagnosis, important for basis exam, Graves disease, Hashimoto disease, De Quervain thyroiditis, postpartum,
Mm.
and also can be simple goiter due to iodine deficiency, and medication like amiodarone induced. What are complications of large goiter? You ask me only for two things. You ask me for shortness of breath, and you
And
ask me for difficulty of swallowing. What you should ask also? What are other complications of large goiter?
sir, if I think is there any change of voice character if there is
Yeah.
laryngeal nerve
Why don't
compression?
ask me about changing the voice?
I forget.
Yeah. So very important also here. Usually here, what the change of voice can be seen due to compression. Hoarseness. We'll see here hoarseness due to compression of recurrent laryngeal nerve paralysis. Okay. So, but we know that also patients with hypothyroidism can also they have change in the voice. The voice will be husky or deep. So you should differentiate between this hoarseness, because large goiter usually will cause compression on the recurrent laryngeal nerve. So will cause paralysis of this nerve, and this will cause hoarseness of the voice. While hypothyroidism itself, due to edema, so will cause husky voice. That voice will be deep, okay, in nature. So to differentiate between, because why we ask about a complication of large goiter? Because if the goiter cause any compression, so this indicate for urgent referral for surgery. You know, Dr. Iron, now why should ask about these symptoms? Because this
Yes, the
indicate,
urgent.
because if you see anyone shortness of breath, difficulty of
Yeah.
swallowing, hoarseness of the voice, so this indicate urgent referral for surgery. So what
Yeah.
are complications as general? You mentioned now three. What other complication of large goiter?
Uh, Complication of large goiter, sir.
Yeah,
I may forget.
Horner's also syndrome, jugular
Yeah.
vein compression and thrombosis, and cerebrovascular steal syndrome. All these can be caused by large goiter. So, upper airway obstruction, dysphagia, recurrent laryngeal nerve paralysis and hoarseness, Horner's syndrome, jugular vein compression and thrombosis, cerebrovascular steal syndrome. Thank you, Dr. Ireland. Really, thank you very much. Only I would clarify some points about how can approach patient with goiter. Thank you, Dr.
Thank
Ireland.
you. Thank you, sir.
Goiter is common in station 5. Very common in station 5 to see patient with goiter. So I advise, first of all, ask the patient when you go inside. طبعا start, introduce yourself, confirm the patient identity, tell the patient I want to talk with you about your health condition, and examine you, because here you should take permission for examination also. Yes, start. It come to my knowledge, or I received letter from your GP told that you have neck lump. Please show me. First of all, see this lump, because maybe this lymphoadenopathy, maybe something else. So see if it's goiter or something else. So first questions I advise, show me your neck. So see the patient neck. No need now to examine. No need to examine. Now only we should take history first. So here, no need to examine. Only see this lump. Here you can ask patient also. This is very important questions. As Dr. Aaron asked me, do you have any other bumps or lumps in your body? Why? To rule out also lymphadenopathy. So that's very important really to see first this is goiter. Maybe only one nodule, you will see nodule only. Maybe you will see multiple nodule. By your eye sometimes you see, not necessary to touch. And sometimes you can see diffuse goiter like in our picture. So sometimes you can see nodules by your eye, or sometimes only can be detected by examination. But really, it's easy to differentiate also from your eyes, by your eyes, if it's goiter, diffuse goiter, or multiple nodule. But sometimes it's difficult, so this will come with examination. Then how can approach patient with goiter? First of all, ask about onset, course, does it increase, decrease, same, and the duration. This is for any symptoms in basis exam. We should ask these questions about onset, course, duration. Then ask, is painful or not painful? What the importance to be painful? That this usually painful can be seen in patient with Dequerdian thyroiditis, post-viral thyroiditis. So first of all, ask whether it's painful or not painful. Then it's very important, very critical. If you forget to ask about obstructive symptoms in basis exam, this is really will decrease your mark significant. Dramatically, your mark will decrease if you forget to ask about obstructive symptoms, because you are unsafe doctor if you forget to ask about obstructive symptoms. And for this reason, we discussed the case of goiter for basis exam. Really, this is the importance of this case. So obstructive symptoms, enough here in exam to ask about shortness of breath, difficulty of swallowing, and the change in the voice pitch. And if the patient tested, yes, doctor, I have a change in my voice, you should know it's hoarseness of the voice or only husky voice, to differentiate also whether this is symptoms due to obstruction or due to hypothyroidism. So obstructive symptoms, then ask the patient if she has any flu symptoms, raised body temperature, dry cough, and other precede the progression of this lump. Why? To rule out also post-viral thyroiditis. It's very important because it came in the exam before, and this is a clue that the patient has painful goiter, painful, and sometimes it's not necessary for the patient to have goiter. It's sometimes only tenderness or pain in the area of the thyroid gland. So this is very important. It's not necessary for patient with Dequerdian thyroiditis or post-viral thyroiditis to see that this patient have goiter. Sometimes only painful and tenderness in the area of thyroid gland, but you should ask the patient these questions whether he has flu symptoms developed before these symptoms. Then I advise to go directly to female history. Why female history? Because female history can give you clue whether this patient hyper or hyper. We know that patient with hypothyroidism has menorrhagia, while patient with hyperthyroidism have oligomenorrhea or amenorrhea. So I advise to go female history directly, and also female history or woman history can give you also clue whether the patient has postpartum thyroiditis. So female history, it helps you to know whether the patient has postpartum thyroiditis, and you can help you to know to evaluate the thyroid status, whether hyper or hypo. Then assess thyroid status. Assess thyroid status. And here I advise only to ask about weather preference. Weather preference is very important. Don't depend on change in the bowel habit or weight change to assess the thyroid status. Why? Because sometimes if the patient has hypothyroidism and has also Addison disease, we know that hypothyroidism causes heart motion or constipation, while Addison disease can cause diarrhea. So this is, you should not depend on change in the bowel habits to know whether the patient has hypo or hyper. Also weight change, we know that Addison causes weight loss, while hypothyroidism causes increased weight. So also you cannot depend, and we know sometimes that Addison disease can be stronger than hypothyroidism in some symptoms like weight change or a change in the bowel habits. So I advise when you assess thyroid status for station 5, for station 5, this is different from approach to station 2. In station 5, it depends on periods in the female patient and weather preference. Better to depend on the weather preference rather than weight change or a change in the bowel habit. Then this is very important also to ask the patient if she if she has, especially if you see that the patient has symptoms of hyperthyroidism, it's better to ask about eye symptoms like gritty eye, dryness, vision acuity, color vision, double vision. Now, this is a very important thing. When you assess thyroid status, if the patient has hypothyroidism or hyperthyroidism, you should rule out other autoimmune disease for type 2 polyglandular autoimmune disease. So you should ask about manifestations of Addison disease, diabetes mellitus type 1, if the patient has, and also celiac disease. So very important. If the patient has symptoms of hyper or hypothyroidism, the first task for you after that to know whether the patient has other autoimmune disease, especially Addison disease and diabetes mellitus and celiac disease. And for exam purposes, it's not necessary for patients in the exam to have all manifestation of the Addison disease, really. And really, it's difficult to see that the patient in the exam basis, it's difficult to see the patient has manifestations of Addison and goiter and hypothyroidism. So sometimes the patient only can give you clue. Yes, doctor, I feel dizzy when I stand from lying to upright position. Yes, doctor, I have tummy pain. And when you examine the patient, you will not see any hyperpigmentation. So you should not rule out Addison if the patient has no hyperpigmentation, but you can tell the examiner, I have suspicion that this patient most likely has Addison beside hypothyroidism because he has orthostatic hypotension or orthostatic dizziness, has abdominal pain, has nausea. But the patient has no hyperpigmentation. So this is very important, and really it's difficult for exam situation to see the patient has goiter and hyperpigmentation in the same time. So you should depends on the other manifestations of Addison. If the patient euthyroid, so if the patient has hyper or hypo, first task rule out autoimmune polyglandular disease. If the patient euthyroid, so the first task with goiter, I mean goiter with euthyroid, the first task rule out MEN 2A. So you should ask patient about symptoms of pheochromocytoma and hypercalcemia. How can ask about pheochromocytoma? Ask the patient, have you ever experienced any spells of headache, shortness of breath, awareness of heartbeat, and fearing? Yes, doctor, I feel these episodes. Do you check your blood pressure during this attack? If the patient check his blood pressure, he will tell you that it's high. So if the patient euthyroid with goiter, so first task rule out MEN 2A. So, and this is for basis wise. In our real life, the approach is different. But in basis wise, they like Royal College like this scenario, especially goiter with MEN 2A, that medullary thyroid cancer, or goiter with autoimmune polyglandular disease. So this is common in the exam situation in station 5. So if the patient hypo or hyper, rule out autoimmune polyglandular type 2 autoimmune polyglandular disease. If the patient euthyroid, rule out first task, but really after you can ask the other manifestation. First task, rule out MEN 2A. Family history is very important because as we know that MEN 2A is autosomal dominant. So family history, it's not necessary for the patient to give you history of autoimmune polyglandular disease. Maybe she told you, like in our scenario, that my mother have hypothyroidism and also vitiligo. So this patient has two components of the disease. Drug history, very important drug history. To ask about amiodarone, lithium, interferon alpha. This medication, we know that this can also cause, like amiodarone can cause hypo or hyperthyroidism, and lithium can cause hypothyroidism and also can cause goiter. Radiation therapy, radiation history, very important to see if the patient has radiation history. As I told you, when the patient has many diseases cause opposite symptoms like hypothyroidism and Addison disease, you should depend on the other symptoms of disease that usually not caused by the other, like weather preference usually occur only in patient with thyroid disease, not occur with the patient has Addison disease. Okay. Yeah. For polyglandular autoimmune syndrome type 2, this is characterized by obligatory occurrence of autoimmune Addison disease in combination with thyroid autoimmune disease, either Hashimoto or Graves. So this is very important. If you have case of Graves or case of Hashimoto, you should rule out polyglandular autoimmune type 2. And also type 1 diabetes mellitus, and also can associated with other disease like celiac disease is common in this syndrome. As we mentioned that this is autosomal dominant. How can examine the patient? This is important. How can examine patient with goiter? Really, this is very important thing. First of all, patient with goiter, during your history, you should know it's hypothyroidism, it's hyperthyroidism, or euthyroid from your history. And during your history also, you should know whether she has Addison disease or no. So if the patient in our scenario told you that the patient have dizziness when stand from lying to upright position, first of all, tell the examiner I should see observation chart. I would check blood pressure in lying and in standing position. Always to rule out orthostatic hypotension, check blood pressure in lying and standing, not sitting. This is very important. And if the examiner told you how long or how much time you should let the patient stand before to check blood pressure, who can answer me?
3 minutes, sir.
3 minutes, very nice, very important. This is very important because sometimes I saw many doctors check blood pressure, only tell the patient lying and then stand, they will check blood pressure directly. This is wrong. You should let the patient stand for at least 3 minutes, after that check blood pressure. And also if we see that blood pressure normal and you have high suspicion, you should repeat it after 5 minutes. Really very important. And sometimes, wallahi, we need sometimes to repeat it after 15 minutes if you have high suspicion. This is very important. So, but usually the optimal time should be at least 3 minutes. 3 minutes is okay. So tell the examiner I would check pulse or heart rate. طبعا in station 5, usually in station 5, they will give you vital signs in the exam paper before to enter the exam room. So also this is very important, and you should know it. You should write in your paper these vital signs, okay? Because this is, you can tell the examiner, I see that in the paper that his pulse like this, his blood pressure like this. You can depend on this. So very important to tell the examiner, I want to check your blood pressure in lying and standing position. Then start to examine the hands. Start to examine, why I should here start in the hands? Because examination in the hands in patient with goiter can give me important clues. First of all, I will see if the patient had an inspection, if the patient has pigmentations, okay, in the pressure area, like nucleus, like shoulders, like elbows, like palmar creases. It's very important. And also, I will see in the hands also if the patient has symptoms of hyperthyroidism, like sweaty hands, or hypothyroidism, like dryness of the hands. So this is examination of the hands can give me clue. And also during the history, if the patient give me symptoms of hyperthyroidism, I should see if the patient has also tremor. This is very important. Also, I will see the patient if they give me also manifestations of Graves' disease. I should see if the patient has also acropathy of for Graves' disease. So put in your mind, this is point. So what I look for in the hands in the patient have thyroid disease or have goiter, I should see if the patient has manifestations of hyperthyroidism, especially if the patient give me in the history manifestations, sweaty hands, tremor, acropathy. And if the patient give me history of hypo, will see the patient has bradycardia, also has dryness of the hands. And if the Addison, I will see the patient hyperpigmentation. Then I will go from hands to proximal muscles. I should see if the patient has any proximal muscle weakness. Then I will see the face. I will look at the face. Usually in patient with hypothyroidism, usually the patient, like in our picture, see this picture. Yeah, You see, this picture also can give me clues that this patient has hypothyroidism. How can? Usually patients with hypothyroidism have puffy face, puffy face with periorbital edema. This is usually typical for hypothyroid patients. Also, I will see the eyes. Here, inspection only. If the patient has proptosis, exophthalmos, by my eyes now, I will see. If there's no manifestations of Graves' disease here, no need to examine the eyes in details. Only should inspect if the patient has redness of the eyes. But if the patient has manifestations of Graves' disease, I should see if the patient has lid lag or lid retraction, and examine also sometimes visual field important, and examine the eye movements to see if there's any ophthalmoplegia, to see if there's any blurred vision or decreased vision. So this is what that time important. But if the patient have no manifestation, the history of Graves' disease and no signs in the eyes, no need to examine the eyes in details. Then I will go to the thyroid. First of all, I should inspect the thyroid from front and from the side, not only from the front, also from the side. And then very important to tell the patient to swallow while drinking water. Yeah, this is very important. When you examine the thyroid from first from front and from side, and I should ask patient to drink water and swallow to see if it's moved or not moved. And then I should, very important to see if there's any scar. This is very important, and this is common in the exam. And really sometimes it's difficult to detect the scar. So really give attention to the scar. Really sometimes it's difficult, especially if the patient has old thyroidectomy or since long time thyroidectomy. So sometimes it's difficult to see the scar. But you put in your mind in any patient who have hypothyroidism or hyperthyroidism to see the scar, very important. Then I will examine the patient from behind. Relax the neck muscle. It's very important to relax the muscle, the neck muscle, to be able to palpate the thyroid. And please, very important really to see, at least in YouTube, you open the video to see how can examine the thyroid. Really very important, because many candidates cannot examine the thyroid in a proper way. And then you should see if the patient, this is goiter, by palpation to see the goiter. If it's diffuse goiter, if it's the patient has nodular goiter, single nodule or multiple nodule, this is very important. This is very important. If the patient has goiter, diffuse goiter, firm or rubbery one, if there's any tenderness, very important. Why? As I told you, tenderness can give you a clue that this is decurvent thyroiditis. And then you should also do percussion for retrosternal extension. This is also important. And then you should listen or auscultate for pulse loops for thyroid bruits. And you should also here examine the lymph nodes, lymphadenopathy. This is finish the exam of the thyroid. If you have more time, you should go to the legs to see if the patient has any myxedema. This is also very important. If the patient has manifestation of hypothyroidism and you have time, you should examine tendon reflexes and also manifestations of carpal tunnel syndrome. But usually there is no time, but you should at least mention to the examiner that I will do this. So here in this case, you can tell the examiner that the most likely diagnosis in this patient, type 2 polyglandular autoimmune disease, depends on the patient has manifestations of Hashimoto thyroiditis and also has manifestations of Addison disease. Any question, please?
Yes, excuse me. Should we ask about symptoms of obstructive sleep apnea?
Yeah, yes, this is important if the patient has manifestations of hypothyroidism. Really, this is, but this case, really, this case, sometimes for hypothyroidism, you should rule out complication, rule out manifestations of sleep apnea and also carpal tunnel syndrome. This is very important in any patient with hypothyroidism, especially if he have gain weight, significant weight gain. It's important to rule out this, and this should be can be by two questions, by Do you feel unrefreshed when you awake morning? Do you fall asleep during the day? This is only 2 questions. And for carpal tunnel syndrome, to ask the patient if he has any numbness or tingling sensation in the hands.
It's okay. Thank you.
Thank you. Okay, if no question, we can go to the second case. So really, for this is an important question from Dr. Shafakat. Any disease cause weight gain, you should rule out sleep apnea. Like any patient with Cushing, hypothyroidism, acromegaly, you should rule out sleep apnea, obstructive sleep apnea. Okay, second case will be with Dr. Who requested with me from. Yeah, Dr. Umayma. Dr. Umayma.
Yes, doctor, I'm here.
Yeah, Dr. Umayma. 1 minute. I will open the scenario. Also, station 5.
Okay.
This is your case. I will give you 2 minutes.
Okay.
Start, doctor, please.
Hello.
Hello.
I'm Dr. Isa. I'm one of the doctors in the outpatient clinic. Are you Mr. Ahmed?
Yes, doctor, I am Ahmed.
Well, Mr. Ahmed, I received a letter from your GP stating that you have been suffering from high blood pressure.
Yes, doctor.
Okay, can you tell me more about that?
Actually, doctor, I'm suffering headache daily. My GP told me because my blood pressure is not controlled well. But nowadays, doctor, this headache become more bothersome.
Okay, can you describe for me this headache? Is it like since the morning or all the day?
Doctor, really affect me all the day, doctor, this headache.
Mm-hmm. I'm really sorry for that. I will try my best to help you.
Thank you.
Okay, is this headache associated with any blurred vision?
Yes, doctor, I feel blurred vision since about 3 months only.
Mm-hmm. Okay, is this headache associated with any feeling sick or throwing up?
No, doctor.
So, Mr. Ahmed, can you tell me when is the first time your high blood pressure diagnosed?
Really, doctor, I have this hypertension since 5 years.
Okay, and what medication you are receiving?
I'm taking 2 medication, doctor. One called lisinopril 10 milligram daily and amlodipine 5 milligram. This added 1 year before.
Mm-hmm. Okay, and what is your measurement of blood pressure?
Really, doctor, not controlled. Sometimes 160, sometimes it reach about 180.
Mm-hmm. Okay, Mr. Ahmed. So, Mr. Ahmed, do you have any medical condition I should be aware of?
Also, doctor, I have diabetes mellitus. This is diagnosed since 3 years, but it's controlled well, doctor.
Mm-hmm. Okay, Mr. Ahmed, do you have any chest pain?
No chest pain, doctor.
Okay. Any high body temperature?
No.
Okay. Any lumps or bumps anywhere in your body?
No, doctor.
Okay. Any loose motion?
No.
Okay. Do you have any? Do you notice yourself becoming more pale?
No, doctor.
Okay. Any awareness of your heartbeat?
No.
Okay, Mr. Ahmed, do you have any weight change?
Yes, doctor. I gained weight over the last 10 years already, doctor. Before I was thin, but over these last 10 years, I gained around 30 kilo, doctor.
Okay, I'm really sorry for that. Do you notice any increase in your ring size or hat size?
Yeah, really, doctor.
Okay,
I need
and
to
shoe size?
I need to change my shoes, doctor, really regularly because it increased.
Okay, do you notice any difference between your previous photographs and your current look?
Yes, doctor, really. I noticed this change in my features like you this, doctor, like you see, doctor. But I attribute, doctor, to age and weight gain also.
I'm really sorry for that. I will try my best to help you. Okay, Mr. Ahmed, can I examine you?
Yeah, please, doctor.
Okay, so I can see the facial feature, and then I
Yeah.
will start by examining the
What
visual
facial
sign.
features now you see?
Okay, this is the enlarged jaw, lower jaw.
Yes, what's you called this
Okay.
one?
Sorry.
What's called this one?
Prognathis.
Prognosism. Okay. How can examine the prognosism?
From the side,
Yeah.
I will see discrepancy between
and
the.
what you should ask patient to do?
I will ask him to open his mouth and protrude his tongue also. There will be
First,
large.
no. I mean for prognosism, ask the patient to clench the teeth.
Yeah. It
So,
will be a reverse bite.
So yeah, very nice. So the lower teeth will overbite the upper teeth.
Yes.
So this is prognosism. Okay, what else you do? You see in the side the mouth.
Yeah, the side also I will see any parotid enlargement.
Yeah.
Okay, then also from the front, I will ask the patient to open his mouth. There will be a gap between the teeth.
Yeah.
Then the tongue also will be of a large size.
Yeah, very nice.
Okay, then
after that?
Then after that, I will examine the pulse of the patient.
You told me the eyes.
Yes, the visual field, I mean.
Visual field is very important. You are right. This patient has bitemporal hemianopia.
Okay.
Okay, what else?
Then I will offer fundoscopy.
Fundoscopy no need, but this is very important to offer at least. Okay, what else?
Okay, then I will examine the skin of the patient, looking for any sweaty skin, increased skin tags.
What does it indicate?
This indicates the hyperactivity of the disease.
Very nice. What else you will examine? The hands?
And the hands, the size of the hand.
Yeah, this is the hands. Okay. What else you see? The skin thickness.
Yes, skin thickness.
In the dorsum of the hands, you will see that is thick. What else you will examine?
It will be a warm and sweaty hand.
Yeah. What else? You would examine anything else?
Skin tags.
MashaAllah. Very nice, doctor. Really, very nice. Don't forget in the exam, please, because this is, if you forget to examine it and it's present, you will lose one clinical sign. So we know that pre-clinical sign will fail. Well, yeah, finish. After that, you have time.
Okay, then after that, cardiovascular system, I will listen to the heart.
No need, no time.
Okay, then I will palpate the abdomen, any organomegaly, any tenderness.
Okay.
Then I will examine the knees of the patient.
Yes, doctor, I have pain in my knees.
For how long do you have this pain, Mr.
Really,
Ahmed?
doctor, since a few months, 3 or 6 months.
Is this pain associated with any stiffness?
No, doctor, no stiffness.
Okay, is it increased by movement?
Yes, doctor, more.
Okay. And then...
One minute, doctor.
Okay, Mr. Ahmed, what is, do you drive?
Yes, doctor, I have car, I'm driving.
Okay, Mr. Ahmed, in the meantime, I will advise you to stop driving because of the vision problem you are having. We will try to sort out your problem. Then we will give you further advice from the DVLA. Is that okay?
Thank you.
Okay, Mr. Ahmed, what is your concern?
Why my blood pressure is not controlled well, doctor?
Okay, Mr. Ahmed, from what you told me and after I examine you, of course, we need to run some more blood tests, but it appears that you might have a condition called acromegaly. This is increase in certain protein in your body called growth hormone. That has multiple reasons. For now, we are going to form a group of doctors for you.
Thank you, Dr. Maima. I advise you, let us start from the end. I advise you don't tell the patient that you have increased hormone secretions from your body, Better here, if you are sure that this patient has pituitary adenoma, to tell him that you have some growth affect one gland in the base of your brain called pituitarism, and better because this patient, it's clear that this patient in our case have pituitary adenoma. So better to tell him that rather than to tell him, and this can secrete one hormone responsible for your symptoms. So thank you, really great. You are great, Dr. Omima, really.
Thank you, doctor. Thank you so much.
طبعا you forget some points, only some points I will clarify for any patient with acromegaly now when I tell you the approach. So first of all, what's your diagnosis?
This can be acromegaly.
Yes.
It can be isolated, or just forget to ask about other manifestation of main disease.
Very nice, very nice, very nice. Really, this is what you should ask. So this is but this patient, because he has now acromegaly, and also what else you should mention? What else? Complication. You should mention complication in this patient.
This can obstructive sleep apnea, diabetes, osteoarthritis.
No, in this patient, in our patient, he has no symptoms of sleep apnea.
Okay, so the high blood pressure and high blood sugar.
Yeah, what else? He told you also?
The vision problem, the bitemporal.
Bitemporal hemianopia, and also he has pain in both knees, can be pseudo gout.
Yes.
So any patient with acromegaly told you I have joint pain, you should suspect pseudo gout. Okay. Okay. What are complications as general in acromegaly? And this is important question, really. This is very important question. Complication of acromegaly, because any case of acromegaly, you should ask about this complication to rule.
Okay. First of all, the cardiomyopathy. Those patient has cardiomyopathy,
Nice.
and then it can be a colon cancer. We should ask if the patient has any GIT problem or any bleeding.
At least ask patient about blood emotion. This is because really no time to ask sometimes in details. So at least you should ask about bloody motion. So this patient can have colonic polyps developed to malignant tumor, and especially if the patient has skin tag. Usually the skin tag, this is associated with the presence of colonic polyps. So for this reason, it's important to see skin tags. So you told me cardiomegaly or cardiomyopathy. You told me also colonic polyps and cancer. What else? In this patient, hypertension.
Yes, hypertension, diabetes.
Diabetes,
and,
visual field defect.
Yes.
So this is what you should ask, and arthritis طبعا, and pseudo gout. So which more common in patient with acromegaly, to have impaired glucose tolerance or diabetes mellitus?
Impaired glucose tolerance.
Yeah, this is also other questions, very important. So it's not necessary for patient with acromegaly to have diabetes, but about 50% will have hypertension and will be refractory to treatment. This is important thing. What investigation you will do?
First of all, we will for diagnosis, we will do the basic blood test with the also sugar level, and we can do the calcium level also for any associated MIN syndrome. And then we will confirm the growth hormone excess.
Very nice. How can confirm growth hormone excess?
The insulin-like growth factors also.
1, 2.
Then the hormone, the
glucose.
OGTT.
OGTT, very nice. Okay, what else you will do for this patient?
Then we will search for the complication. We will do ECG and echo, and then we will do the MRI for pituitary glands.
Very nice. So this my question. Why always when you suspect pituitary adenoma, we should start our investigation by lab test before to go MRI? Why? I mean, either prolactinoma or Cushing or acromegaly, it's advised to start with to document the growth hormone excess, or to document ACTH excess, or to document prolactin excess before to go MRI. Why?
Because they're
Incident
Because what you should,
Functional or non-functional?
functional.
because sometimes microadenoma cannot be detected by MRI. Because if the tumor less than 2 millimeter cannot be detected by MRI. But we know that most prolactinoma will be microadenoma, and this cannot be detected by MRI. So if I go to MRI directly, maybe I will not detect anything. So I should know what's the cause of this increased secretion by lab test rather than to go to MRI. So what's management of acromegaly, doctor?
First of all, definitely,
for our patient, how can manage him?
our aim will be to control the blood pressure and optimize the sugar level. And after investigation, the definitive treatment is surgical. But meanwhile, we can use somatostatin analog. We can use pegvisomant if there
So
is.
the treatment of a choice for patient with pituitary adenoma. What?
Surgical.
Surgical. So this patient, first of all, because he has also bitemporal hemianopia, you should tell the examiner this patient needs urgent referral for neurosurgery because he has bitemporal hemianopia, to show the examiner that you are safe doctor now. The patient has complication. Okay, and this can be irreversible if the develop more and cause axonal injury of the visual fibers. This is very important. Okay. So first of all, this patient needs urgent referral for neurosurgery for transsphenoidal hypophysiectomy. But then, if the patient has persistent symptoms, because this is very important, that transsphenoidal hypophysiectomy in acromegaly can be curative in 90% of microadenoma and 50 to 60% of macroadenoma. This is very important. Why? Because this patient maybe need adjunctive therapy. What's adjunctive therapy?
Medical therapy like octreotide.
What octreotide? What the group of octreotide?
It is somatostatin analog.
You mentioned. Yeah.
Then,
What else?
growth hormone antagonist, pegvisomant.
Very nice. What else?
Then we can. There is a choice of
dopamine agonists like cabergoline and bromocriptine. So we have 3 groups of medical therapy: somatostatin analogs, dopamine agonists, and growth hormone antagonists. And also we have radiotherapy. Okay, so very important. So the treatment is transsphenoidal hypophysiectomy. Okay, my question for you now, doctor. If the scenario come in the exam, like this scenario, but the patient tell you, I have no visual problem. I can see well, I can see the sides well, I don't bumping into the objects. You will examine visual field or no need that time?
We should.
We must, not we should.
Yeah. Yes.
We must. Any case suspected that can be caused by pituitary tumor, you must examine visual field, because if you forget, even the patient has no symptoms, this is very important. So now the first task for examination in this patient should be visual field, because if you forget to examine visual field, you will fail in the exam. Really, be sure.
Yes,
so very critical.
Patient is having headache also. This can
be. Patient with Cushing, patient with the acromegaly, critical to examine visual field. And if you see patient in the exam, also to spot diagnosis, Cushing disease, and if he tell you, I have no headache, doctor, I have no blurred vision, you should examine. You must examine. Why? Because sometimes we know that, especially at the early stage of the disease, maybe only visual field will be involvement or impairment will be detected by your examination. Maybe the patient will not report that I have visual problem. So for this reason, and this is what happened in the exam before. Many patients tell you, doctor, no, I have no visual problem. When you examine them, you will feel, and this is in our real life also. I see many patients, when you ask him about visual symptoms, because why? Because bitemporal hemianopia, only it causes that when the patient walk or drive, he will not see the sights very well. So he can sometimes in a crowded area bumping in the other people or like this. But if the patient walking in normal area, not crowded, so he will not feel that he has something really. So it is very critical to examine the patient, not only to ask him. Last question, what are causes of acromegaly?
Apart from pituitary adenoma or hyperplasia.
Hyperplasia of what?
Of the pituitary.
Usually not hyperplasia, no, only adenoma.
I'm not sure if there is ectopic or not.
Yeah, ectopic, you are right, So this is can be asked, but rare, it's rare, but you should know this. Ectopic growth hormone production from carcinoid or small cell tumors. And also there we have also other rare cause like growth hormone releasing hormone, hypothalamic tumor. So we have pituitary adenoma, growth hormone releasing hormone, hypothalamic tumors, and ectopic growth hormone reduction from carcinoid or small cell tumor. So in the exam situation, because it came before many times, you should rule out min 1. How can rule out min 1?
First, we ask the patient if there is any symptoms of hypercalcemia, constipation.
Nice. No need, no, doctor, you see, in station 5, only 2 questions, because in station 5, you have no time to ask about all. What the important question of hypercalcemia? Polydipsia and polyuria.
Okay.
You see, because really no time to ask constipation and very important, polydipsia, polyuria. And for also for what else you should ask?
Pancreatic.
Yeah.
Maybe insulinoma or
yeah. Usually the most common in the basis exam, Zollinger-Ellison syndrome. So you should ask patient about watery motion and recurrent heartburn or epigastric or ulcer. We know that usually the patient with the Zollinger-Ellison has refractory peptic ulcer disease. So this is very important question. So I will make, inshallah, the scenario today very easy. Acromegaly, very common in basis exam. Very common, especially in some centers like Oman centers and UK. It's very common to see patient with acromegaly. And really the scenario, there are many scenarios. But whatever the scenario, the diagnosis of acromegaly is a spot diagnosis. Like you see in this patient, you will see when you go in the inside the examination, you will see a patient like this. It's sometimes really it's difficult to detect the patient that he has acromegaly only from facial appearance. Really, sometimes difficult. But most likely or most commonly in the exam situation that can be easily detected, so it's considered spot diagnosis. That means from first look you should know that this patient has acromegaly and your approach should be approach of acromegaly. So first of all, when I see this patient features, whatever the complaint outside, I should first confirm the diagnosis. I should ask patient if he has any change in the facial features, change in the size of hands and feet. This is first of all. If the patient tell you, yes, doctor, I have comparison on the old photo, so now I know that this patient has acromegaly. This first task. Second task, I should now rule out complication. What are complications I should rule out? Hypertension, diabetes mellitus, bitemporal hemianopia by asking the patient about blurred vision, optic atrophy, this is also blurred vision, cardiomegaly. Enough to ask patient about shortness of breath and awareness of heartbeat. Pseudo-gout, do you have any joint pain? This is very important. Sleep apnea, do you feel unrefreshed when you awake morning? Do you fall asleep during the day? Only these 2 questions. Carpal tunnel syndrome, colon cancer. Colon cancer can ask only bloody motion. It's enough in the exam situation because no time to ask all questions. And then you should rule out min 1. Very important to ask patient polydipsia, polyuria, and ask patient about chronic diarrhea, especially watery diarrhea. This is enough. Really, it's enough in the exam because really you have no time. Also now you go to examine the patient. And really in this patient, because Dr. I forget the name really, I'm sorry. Dr. Umayma. Because Dr. Umayma told me, I will examine the heart, I will examine the abdomen. Really, how can examine the heart and abdomen in this station 5? You cannot. Really, be sure you cannot. So really very important here, depends on what the patient he have during your history and go to the exam. Example, if the patient tell you, I have numbness in my hands, so you can examine the carpal tunnel syndrome. Other than, no need. If the patient tell you, I have shortness of breath, I have awareness of heartbeat, yes, examine the heart. But if the patient tell you no need to examine the heart or chest, but you can, at the end, tell the examiner, I will do full examination for the patient to rule out any cardiomegaly, to rule out any other symptoms, okay? But as general, no need to examine all parts because no time, be sure no time to examine all. Here in this patient, enough to inspect his hands, inspect his face. Very important to see skin tags in the neck and the axilla, and also see the goiter because many patients of acromegaly have goiter, and also examine visual field. Okay. Sometimes if you have time, so you can also see the patient other manifestations like gynecomastia. Also, this can be seen in the patient with, and this is one of complication, but this can be detected by examination, or you can ask the patient, do you feel that your breast size or your chest size become large? What are signs of activity? Signs of activity, the patient has sweatiness. This is indicate the patient has active disease, and also the patient has ongoing enlargement of the hands and the face, and also difficult to control hypertension. Why this is important? Because it came before in the exam case of acromegaly, patient underwent surgery 20 years before, and nowadays the patient present to you with symptoms of headache, blurred vision, and also sweatiness in the hands, and also, so there is possibility for recurrence of a tumor. 2 to 3% of patients with acromegaly underwent surgery can relapse after many years of surgery. So also this is important scenario. And one scenario came before that the patient has lower GI bleeding, and when you see the patient has features of acromegaly, you should rule out also colon polyps and malignancy. Very important to rule also malignancy. When you explain the patient the disease, you should tell him that you have a growth in the gland at the base of brain, and this causes increased secretions of specific hormone called growth hormone, and this is responsible for your treatment. And this patient, very important to mention for examiner, need urgent referral. This is first step to show the examiner that you are safe doctor. You know when you should refer the patient urgently to that doctor. But urgent referral not mean today I will refer him, but this patient should be investigated and seen within 2 weeks by neurosurgeon. Really, it's very important. How can examine the patient? Also, this patient tell the examiner observation chart most likely in the station 5 should be written in paper exam outside. So you know from outside the patient's blood pressure, you know heart rate, you know everything about this patient from outside. For examine the hands, you should see the hands. You will see that the hands large, sweaty hands. Sometimes that's necessary, especially for patient on treatment, to have sweaty hands. With broad palms, as you see in the picture, I will see the picture. Yeah, this picture, very important. See the hands. What you can see the hands, you see the fingers also, you see the fingers broad and rounded. This is what's called spatulate fingers. Spatulate fingers. So the fingers you see rounded and also broad. And also the palm will be broad, and the skin over the dorsum of the hands will be thickened. See the face. Really very important in station 5, especially if the patient has findings. This very common question that examiner asks you, what's the findings? What's your findings in this patient? This is very important. So really you should remember what you see in this patient. So if the examiner tell you, what's your findings? So you should tell him that this patient has large, broad palms and spatulate fingers. The skin is thickened, and see the face. The patient has prominent supraorbital ridges, enlarged nose and lips, and also prognathism. What means prognathism? As I told you, that malocclusion of the teeth, where the lower teeth overpile the upper teeth when the patient clench his teeth. And you should also tell the patient to open his mouth to see if there's any interdental separation and if the tongue is enlarged. And this is very critical. This is need only to look by your eyes, to look for, to see if the patient has skin change. And this is what you should remember. Now, when I'm preparing for examination, when I'm studying the case of acromegaly, I should study like this. I should read this case like this. The symptoms, what I ask the patient inside: headache, blurred vision, change the feature of the face, symptoms of pseudo-gout, symptoms of cardiomegaly, diabetes, hypertension. I should ask the patient, and I should study also what are signs. When I will try to examine patient, I will see, yeah, I should see skin changes. Why skin changes? Because many people or many candidates forget to examine this, and this is what happened with the one candidate. Forget to mention to the examiner that the patient has acanthosis nigricans, and the patient it was present in the patient, and really he lost one clinical sign. And we know if you lost 3 clinical signs in the examination at all, you will fail in the exam. So if you have any patient with hypothyroidism, acromegaly, Cushing, you should see skin changes, especially acanthosis nigricans. And also you should see skin tags. Very important to see skin tags, and also hypertrichosis. As I told you, patient can have also goiter. This is what only need you to know these findings. So when you inspect the patient, you will see it. But if you don't know these findings, this will not be remembered in the exam. So before to go exam, you should know that patient with acromegaly can have goiter, can have gynecomastia, can have acanthosis nigricans. So only needs from you in the exam only to look the patient, and you will find, inshallah. And then visual field, critical, very critical. Even if the patient has no symptoms, no eye symptoms, I should examine visual field. And I will tell the patient, the examiner, I will do fundoscopy. Here, no time, and the examiner will tell you no need. And sometimes the examiner can tell you the finding, can tell you that this patient has papilledema, can tell you the patient has optic atrophy. This can be told. And then, according to your history, you can also guide your examination. If the patient has cardiac symptoms, yes, you can examine the heart. But really, no time to examine all parts. So examine acromegaly to elicit the features, and also visual field, and also skin changes, acanthosis, nigricans, and skin tag. Any question, please?
Dr. Hassan, you told that this patient might have goiter. So can you explain goiter?
This is what's written in the references, that patient with acromegaly can have only goiter, enlargement of the thyroid gland, without any manifestations of the thyroid. Because we know, as I mentioned for you, acromegaly, this will cause enlargement of all parts of the body. Also, their liver will be enlarged, their heart will be enlarged, all parts. Also, the thyroid gland will be enlarged. You understand me this point, doctor?
Yes, yes, doctor. And as you said that, as the other doctor said that we have to examine his abdominal organs. If we have time, so we should examine abdominal.
Yeah, if you have time, but really be sure that in the exam, in case of acromegaly, you have no time. Why? Because during the exam, you should first of all confirm diagnosis, rule out complication, ask about main 1, okay? And also, when you examine the patient, you should examine visual field. Examination of the visual field itself will take from you about 30 seconds to 1 minute, you know. And also to look for signs, skin signs. More important to examine the abdomen, because most likely you will not find in the examination of the abdomen anything. But if you miss these points like acanthosis nigricans and skin tag, you will lose many marks. Especially that the examiner will ask you, what's your findings? This is common. This is if there is a finding in any case, This is common questions. What's your findings? This is very common question, especially in the patient with acromegaly. What's your findings? You should tell him what do you see in this patient.
And regarding prognosticism, we should examine the patient in front or from the side, and then we
No,
should.
from you see this is picture. Yeah, you see this picture. I will show the picture. Yeah, from you see from side. It's clear now more, huh?
Yeah.
But only if you ask patient to clench his teeth, it's from front you will be clear also. You will see that the lower teeth will overbite the upper teeth.
So we should say the patient that open his mouth and then clench teeth. Okay.
Yeah,
right?
clench teeth, yes.
And also, doctor, you mentioned about pseudo gout. So can you explain the mechanism of pseudo gout with the
this
acromegaly?
we know. Well, I cannot tell you really. I don't know because as I told you, I am here for basis approach, for basis information. But really, how what pathophysiology this is can be read by any reference. Really, I don't know what the mechanism.
Okay.
But really,
Okay,
acromegaly, important cause of pseudo-gout, and this is appear in the exam many times when approach patient with swollen knee. Swollen knee can be acromegaly as pseudo-gout.
Dr. Hassan?
So that also needs, I think, aspiration of the joint if there was any fluid.
Yeah. If you have any suspicion, you can tell in the approach in the examiner questions about that. I need also knee aspiration to rule out pseudo-gout.
Okay. Thank you.
Okay, doctor. Yes, doctor.
Doctor, can we say also this patient can have osteoarthritis because of the increased weight?
You are right. You are right. But really, so you can't. I told you, arthritis as general can be associated with the acromegaly patient, but because it's common also in the basis exam, they like this. It came many times before in the exam that patient have a swollen knee and features of acromegaly, and the diagnosis was pseudo gout. So you can mention for the examiner that also this patient has manifestations of arthritis, can be osteoarthritis, can be pseudo-gout, can be other type of arthritis. Yes, you can mention. But always put in your mind pseudo-gout. This is because already it's associated with acromegaly, can only to be seen in patients with acromegaly.
Okay, tamam, thank you.
Thank you, doctor.
Dr. Hassan, sorry, complete, doctor.
Yeah. Yes, Dr. Sayyid.
Yeah.
Doctor, yes.
When I read when I received the complaint from outside that the patient is not controlled blood pressure in spite of the first thing came to my mind how to make differential diagnosis of uncontrolled diet. The first thing is that non-compliance of treatment. This is the first thing came to my mind before I saw the picture. This non-compliant for treatment, any addition of any treatment like hydrocortisone or this. Yes.
Yeah. We have in station 5 what's called spot diagnosis. I mean, you read something outside, but you will go inside, you will see the patient like this patient, or you see Cushing patient. So when you see this, so now your approach for Cushing disease. When you see patient with acromegaly, your approach for acromegaly. Yeah. Outside, when you read that this patient has uncontrolled hypertension, you should write your differential diagnosis. You should approach the patient as hypertension, but really be sure that inside everything will be different. Okay. So Dr. Said, now go inside the exam, see this patient. Now, khalas, everything written outside, forget it, because now I have something else. I have other task now. For this reason, you should prepare these cases of spot diagnosis very well, because sometimes from outside you cannot detect that this patient has Cushing. You cannot predict that this patient has acromegaly. So you should, before to go exam, this is common cases like case of acromegaly, Cushing, Graves' disease, rheumatoid arthritis, scleroderma. This is all these cases called spot diagnosis. Why? Because when you go inside the exam, by one look you will know that this patient had this disease. So after that, you should follow this. You should follow this approach.
Wow.
Do you understand me, Dr. Sayed? So for this approach, you should repeat the preparation for this. You should be fluent in this approach. Ready for acromegaly, I should be very fluent. How can, I should ask the patient? How can examine the patient? I should not remember inside the exam. No time to remember. Also for Cushing disease, I should know from outside. Inside, I should know directly now. What's the question I should ask patient? How can examine the patient? For rheumatoid arthritis, also same thing. So this case of spot diagnosis.
Okay, doctor. Okay, thank you.
Other question, please.
Dr. Hassan, if this patient is not acromegaly,
yeah,
and outside the written the uncontrolled hypertension,
yeah, this is
usually, what is the approach?
Yeah, yes. طبعا we have inshallah Dr. Ismail in the future I have case where we discuss about how can approach patient with hypertension, but usually this is in station 2 rather than station 5, but I should inshallah in future I have one case to be will be very clear inshallah before to go exam inshallah also.
Doctor, from the next year the approach I think will change, isn't that? The stations, I think. The PACES exam.
Next year, yes, since I think diet 2, I think diet 2 or diet 1 will change the exam. Diet 2
I think diet 3, doctor.
3 also. So until that time, we will inshallah will approach patient in the old format.
Because now the diet 3 is over, I think, for this year.
I think when doctor mentioned for us that this will change, as Dr. Sayed mentioned, that they sent message for them and they told that will change in the diet 3 2021.
So diet 3, sir.
Yes, the diet 3 2021. Yes, it is also mentioned on the website.
Yes. So up to that day, until that day. So
okay. I think they postponed it due to coronavirus.
Really, I will tell you something. A new format, this is new format will be more easier than this old format. Really, be sure. Why? Because really, the time will be good for you to examine, to ask the patient. So I think will be better for all.
Yes, hope that it will be better.
Hope. I think hope will be better. I think. Because really nowadays station 5, 8 minutes sometimes can be enough, but sometimes it's difficult to manage everything within 8 minutes. And Royal College really know sometimes this one, they know this issue. So for this reason, sometimes give you clue from beginning. Either the patient will tell you all clues, or from outside in the scenario they wrote clues. Even that we have sometimes difficult cases in the exam, but really will give you clues for this case.
Okay.
Thank you very much for all. See you next week. Inshallah.
Thank you, sir. Inshallah.
Thank you very much.
Alaikum salam.
شكرا دكتور. السلام عليكم.